Oh, sorry, you can see my screen and you can hear me.
Yes.
Yep.
This is the screen, so you can see it. Okay, now you know Nour, and okay, let's start it. Let me minimize this screen again. Okay, so when I had this invitation to talk about basics, actually, when I was in medical school, maybe I don't know anything about MRI or physics or anything. We just care about maybe X-ray, CT, but I guess as a medical student, this is a good opportunity to be involved in MRI. At least you hear about something. If this will be your career in the future, or this can help you a lot about your research work. And I tried to emphasize today more about which things that's important for you during your practice challenge. As I worked before, and I know a lot of things that as a radiologist we keep like thinking, is this a cyst or is this like a necrosis? What's going on? Is this part of ventricle? So I try to make it simple as much as I can, and try to emphasize on the important issue as well for you. So I will start to talk about, like, give brief introduction about MRI basics, so you can understand how we acquire images. When I talk about T1, T2, I don't know which level that you are in this knowledge, but I wanted to start by that. Then I will give you a review about the anatomy as well. One of the biggest challenges to read MRI is the artifacts, and also I will give you a brief about this, and we'll talk about the pathological consideration as well. I feel it's worth to talk about people who start to invent the MRI. This started in 1977, and you can imagine how is this hard, and the people here in the magnets, and yeah, they start to acquire images, and here is the images, the first MRI images that I found online. And you can see now the difference between what happened and the innovation, and we are part now of this innovation, right? Because we try to also work with artificial intelligence, and this can help a lot. Maybe after 10, 20 years, people start to talk about us, how the MRI was, and how the radiologist start to pick every single lesion, and now the artificial intelligence can do everything. So it was to talk about what happened before and how this developed. And you can see now this images that we got every day, that we read the axial cuts for MRI brain, this T2 scan, and how the images is so clear, and you can see the tissues, the contrast between the tissue and the fluid and everything. You can recognize single lesions. And I know physics is not my interesting topics. I don't know about you, but I have to start by some like physics to talk about. I know it's boring sometimes, but just try to pick what you can with me. When we talk about MRI physics, we start by our body. So our body has components like multiple nuclei, and the most familiar and the most famous nucleus in our body is the hydrogen. So we can find hydrogen in every single tissue, right? And this is the most common nucleus in our body. That's why we are always keep focused on hydrogen in MRI, as it also has a single proton. Simply, we can talk about hydrogen. It has single proton, and it has two movements. First, it is spinning around itself, as you can see. Unfortunately, I didn't put much videos, so you can imagine this is the spinning movement. And when there is a magnetic field applied to the proton, start to have two movements. So one movement around itself, like the spinning, and the precision around the magnetic field as well. And one of the things that happen for our tissues when start to have this movement, it does start to induce or creates electric current, and this electric current creates a signal when it's it has a radio frequency when it hits the radio frequency coils. And this signal we can measure, so we can see our images after that. Okay. And here we have like axis. So the main axis is the z-axis. Now you can see is like randomly here every single proton in different way. When you apply the magnetic field, everything is start to be parallel and aligned. There is only one proton here is not parallel and is going to against the magnetic field, maybe, but most of them are aligned with the magnetic field, and this is a net magnetization. So as much as the magnetic field, like as much is higher, all the protons align to the same like the same direction of the magnetic field. That's why we prefer the higher magnetic field. Like so we start initially, I think it is this in 1977, they started by 0.05 Tesla, something like this, and I know now we have like 7, 9, 11, maybe 15 Tesla now. The previous hospital that I was there, we have 7 Tesla. Maybe this is not common in every place, but it gives a very clear, very sharp pictures, because every single proton is parallel to the same magnetic field. You don't have like this way against the way of the magnetic field. So the net magnetization can be helpful for clear images. And when we start to do like the MRI images, to acquire images, we have this z-axis. We always call z-axis, and this will be the same axis the patient will be aligned. And it's also called as B0. And the magnetic field is permanently switched as on. And at this way, as I said, we have high energy and low energy protons, and the high energy is aligned with the magnetic field. The low energy is aligned with the magnetic field. And you can imagine like a weak proton, so the magnetic field has upper hand, and it takes it in the same way, and like the high energy maybe object, so it's like aligned in the opposite way. And always we will call the longitudinal magnetization as MZ, so we refer to as Z-axis, and when we have a magnetization, it's MZ. And unfortunately, we cannot like measure our magnetization in the longitudinal axis. So this is the Z, the longitudinal, and this is the transverse. And you can see here the proton is here, start to have the spinning movement around the magnetic field. And we call this as B0 or Z. And when there is a radio frequency pulse is applied to the proton in this direction, start to change the direction to the transverse. And this we called as Y. This gives like 90-degree change of direction. And like with time, this is like start to decrease, and this is start to increase after the application of the radio frequency. And this is called also like a flipping 90-degree. So just to remember, this is the Z direction, this is the XY direction, the transverse plane, because it's also important for our, this is important for creation of our T1 and T2 images, okay? So here, for example, when we switch it on and off, see now, this is the direction now in the transverse, and this is named the transverse magnetization, and we are able to measure the transverse magnetization to have images. Yeah, and now I'm talking about the T1 creation for images. So this is named the spin lattice or longitudinal relaxation. So we said originally it should be in the z-axis, and when we have a radio frequency pulse, it will transverse to the other side. But in between, this z-axis start to decrease and relax. We call like relaxation here. When we have a 63% of this relaxation of the time, we call this like T1. So T1 we can acquire at 63% of the time. Okay, and and this is the images for T1. You can imagine how it looks like. I don't know how your previous knowledge about the MRI, but I can start so simply as I started to learn this. Okay, I'm looking at T1 in brain. So T1, the fat is short and there is like mnemonic you can hear about, like they said, long drink of water and short fatty like junk food or something. It's short. So when T1 short of time, this happened with the fat and it appear as bright. So everything is short. T1 has a bright signal as fat. You can see here the fat in the intraconal fat of the orbit. You can see the fat here is a bright, and as well as the white matter is also has a fat, so it's bright. And again, you can see here the fat here in subgalial or subcutaneous tissue, it's hyper as well. So at least now you know the fat is short T1 and it's a bright, because it's like a large molecule and it starts to absorb energy very quickly and recover very quickly. Okay, and this opposite to the water. So now, at least you know the globe has a water, right? And this is hypo, it's dark. So when we say dark in T1, this means a fluid or water, okay? And the reason behind this, because it's long T1. As you know, the water is like a small molecules and it start also to move quickly and make like inefficient absorption for energy. That's why it appears dark in T1. You can say, for example, okay, I see here this is also dark. Is this a fluid or is this a water? I would say no. If you notice the difference between here and there, this is more darker. This is air. So air is always dark like this. Okay, and again, so this is the paranasal sinuses. You can see always air, since no mucosal thickening or something like this. And again, you know, here, this is like the CSF spaces. It's between the sulci here. It's dark, like any fluid, like CSF. And here the basal cisterns are also dark. Regarding the bone, calcium, and the metals, it is very long, and because it's like a macromolecules, and also it's less effective to have energy. So you can see here this like a calvarium, you can see it. It's like intermediate signal. Sometimes the calcium can be also bright or intermediate signal. It's this part of the bone as well. You can see it and see the difference between the bone and the globe and the white matter and the fat. So like once you have like cortex of bone like this is very dark, maybe here is like an intermediate signal. It depends on the For calcification, depends on the stage of calcification, and for the bone as well, it depends on the type of bone. Like, for example, for vertebra, if you look for vertebra, it's like a bright in T1. And now talk about T2. Okay, so this is spin relaxation. And again, we talk about the Z and XY axis. I'm trying not to go deep into the physics, so you didn't feel bored or something, and try to relate the physics to the images that you see. So here, as you can see, we said once we have like a radio frequency pulse, it will be changed to the transverse axis, right? And before it start to create here in this direction, it's at 0. So here the XY is at 0 with after the 90-degree pulse, and start to build up here in this direction. Once it reaches to the end, it's like 100%, and then it will be decay. So we call the time when returning back to gain again in the other direction, like when the radio frequency pulse action start to fade out. Well, once it returned back here at 37% of decay, we can have the time for T2. So T2 at this time. So you remember here T1 as this time when we reach to 63%, and after you give the radio frequency pulse and go to the other direction, and in decay of this, it give you, once it reached to 37% of the time, this is can be measured as T2 until it reached to 0 again. So it started here by 0 and ended by 0. In the middle, you can catch the T2. Okay. And this also MRI brain images for the T2 axial cuts. And now you can imagine how it looks different between the T1 images that I show you and the T2. Can someone, like, just to make it interactive, can someone tell me what's the difference that you notice between the other images and this images? Regarding, like, the components of the image, anything. Like, for example, the white matter. Yeah. Say that again.
Bright CSF and darker fat.
Yes. Okay, that's a good thing. And what about the fluids here in the ventricles, like the CSF? How it looks like?
It's bright.
It's bright.
Right, exactly. So this is the opposite for T1, right?
Yes, exactly.
And yeah, and you notice the white matter is dark here, right? So this means that the fat is not bright like the T1. Still, we have some fat here, but the fluid is bright. Okay, so in T1, we mentioned the fat is short, right? Now the fat is also short in T2, but it gives us like this signal, and it's not bright like T1. And what about the fluid or the water? We mentioned the water is long in T1, and it is very long in T2, and this means everything is very long in T2, so it will be bright. Okay, like a fluid. Once I said short in T1 is fat, long in T1 is fluid and it's dark. If we mention long, very long in T2, it is like a water and it's bright. Okay, and you can appreciate that. Now again, for the bone, calcium and the metals, it is short because it's like solids and the macromolecules, so that's so rigid. You can imagine once the tissue is flexible and can move with the magnet or can give magnetization, this is different than the tissues that rigid like bone or cartilage or like calcium, metals. It doesn't move, right? So it doesn't give much signal. The same like air, it doesn't give signal. Okay, so again here we can see the air is dark signal in T2. Another thing that I want to show you here, maybe I will explain more in the next slides, but just look at this. 2 dots is black, right? And here there is dot also black. There are some dots here black. Anyone knows what is this? Or you can imagine?
Vessels.
Yes, exactly. That's vessels. So the vessels is like moving in very, very fast movement in the blood vessels. And so the blood movement is very fast and it doesn't like catch the signal in the T2. So you can see it as a, so we called it as flow void. And this is normal.
Signal.
So yeah, so when you say a flow void vessel, this is normal. Which is abnormal when the vessels start to be thrombosed. So there is like something inside catch a signal, like a thrombus or dissections. Also, dissection has like a thrombus in the wall, and you can see like maybe a bright signal in the wall or like it's occluded. So once you see this is not a signal void, this means occluded vessel. It's abnormal. Okay. Once you see it is like a flow void, that's good. And you can see also here there is a flow void signal. There is a flow void signal. This part probably of the sinus here, also part of the sinus. So the venous sinuses and the cortical vessels, blood vessels here, all of them has signal void, and we can recognize the thrombosed vessel from the healthy vessel by this sign. And again here I want to show you there is difference also here between the gray matter and white matter. So you can notice the gray different than, okay, let me return it back to T1. So gray matter in T1 is gray and white is white. Okay, you can recognize like this. So white matter is here is white, gray is gray. Let's go to the T2. Maybe it is the opposite. So you can notice here the gray matter is brighter than the white matter. The white matter is dark. And this due to, as we said, the fat and the myelin sheaths and the stuff in the white matter. And again, here, this is one of the gray matter, right? So the gray matter, you can say it's brighter than the T2, the white matter. So you can differentiate here, like, for example, the codeine. You can differentiate the butamin here and the internal capsule, external capsule. You can like differentiate the difference between structures here, the thalami. See how it looks like. So the basal ganglia looks like different than the white matter. And this is perfect in T2 as well. And also you can see here the subarachnoid spaces has CSF, and you can see the CSF is like a bright, as we said in T2. Again, here's a cistern and the lateral ventricle looks like a bright, right? Okay. So in MRI, we have different substance, either inside our body or outside our body. Like sometimes patient has a artificial valve, or they have like a knee replacement, or they have like sometimes like a stent or something like this. So we have a different categories for the tissues. Like, for example, we have a diamagnetic, and this has a very weak magnetic. Okay. And like when we called like a tissue high magnetic or low magnetic, so the diamagnetic, like the water, fat, collagen, protein, and calcium, and oxyhemoglobin. This like a diamagnetic. The paramagnetic is like little bit stronger, like the gadolinium. That's why we are using the gadolinium in injection as opposed to contrast. when the patient has like a tumor, we didn't just do T1. If patient has a stroke or something, maybe we can do just T1. But I mean, no need for contrast unless we have some other like findings or if we are suspicious about something. But every patient has a tumor, we have to give contrast. So this, for example, the gadolinium. Also, the other melanin has also paramagnetic, and the magnesium, the methemoglobin, this is also involved in patients who has hemorrhage. So this named the paramagnetic, and this is stronger than the diamagnetic. And it has the effect of T1 shortening and start to be bright. And the supramagnetic, like ferritin and hemosiderin, this is dark. And the ferromagnetic is very, very strong. Magnetic, this like iron or cobalt or nickel. And you can imagine some patient, if they have something like this, sometimes if patients have rash or something in his, like he got a bullet or get, like he's working with iron or something and he get like a small piece in his eye or something, maybe we cannot do MRI because it starts to move. If we put the patient in the magnet, this small thing in his eye start to move and can damage his eye. So maybe we cannot like scan him. So this is important to know if the patient has nickel or iron in his body, because all of this is ferromagnetic and has very strong magnetic field. And they can cause heat or can move from the place, cause damage to surrounding tissue. So it's important, like it's worth to know about the different tissues and how we categorize this. Okay, and now this interesting part, the anatomy review. This is very interesting for me, and I hope it is the same for you. I put like T1 in comparison to T2 because this most of the time you are working with both of them. So here T2, anyone notes anything about T2 here in difference to T1? I know for sure the fluid is bright. It should be. What about the fat here? So this is
Fat
not
is suppressed.
Yes, exactly. Who said that?
It's darker, in the dark.
Yeah, exactly.
Very dark.
Yeah. So this technique, we suppress the fat. We mean to suppress the fat. So any lesion or any bright signal, this means it's not fat.
It's
If
fluid.
it is, yeah, if it's in the place for fluid, okay, it's a fluid. But what if I found here something bright? No, this lesion. What if I found something in the muscles here? This is a mass or something. So it helps us to suppress the fat so we don't be confused by the fat, because here it's very hard to catch if everything is bright. Like, okay, for T1 still you can differentiate by hypo signal in fat, but in T2 is very hard because everything is bright. The soft tissue is bright because there is water, and anything has a water, it has a high signal. And if that's also high signal, it will be very hard to catch any lesion or differentiate between the tissues, right? So usually we are using this technique in head and neck tumors. It help us to see, because head and neck, it has a lot of like fat there, and we have to suppress so we can catch anything small few millimeter lesion. Okay, and also I want to ask someone else. Okay, what do you think about this or this and this very dark circle here?
Vessels.
Yes.
Vertebrae.
Some vessel. Yes.
Great. Okay, that's good. That means you are still awake. No one sleep from me during the physics part. Yeah, that's very important. See, it is a flow void, right? So it's healthy. It's a flow void. Usually, when we are looking for dissection, it's important for us to look for this plane exactly, because we are looking here at the internal carotid here and the internal carotid in the petrous part. If there is anything signal, we catch any signal here, maybe we think about dissection or and I wanted to tell you, like, a lot of radiologists miss this part because they are looking at the brain, looking at everything. They miss the part of the skull base. And it's important to look at the blood vessels, the flow void. Once you find it, okay, that's good and that's clear. Okay, so let's talk about this. This is the cerebellum, the right lobe, the left lobe, and this is the vermis here, and this is the medulla. You can see this is the lower part of the brainstem. And again, here is this air because it's the sinus, and you can see the soft tissue, like the turbinate. It's so this is a mucosa. It has a lot of fluid, so it's a bright here, it's dark here on T1. And this is the muscles, like in the masticator space. You can see part of the bone here, part of the bone, and you can see the cortex of the bone is very dark because here in T1 is very dark, and the fat is suppressed between here and there. You can note the difference. And again, and this is part of the nasopharynx. Here is the mastoid air cells, and again, it has air. That's why it's dark in both. So the air is dark in T1 and T2. It is similar. And also, this is C-SEF spaces, the premedullary, and here the part of the fourth ventricle. You can see the fluids here very well, the C-SEF, and you can see foramen Floschka here. Okay. And next up, when you go scroll up a little bit, you can see the cerebellum start to like ends here, and you can see part of the bones here. Do you know what is this part? Anyone know? Was in the dorsal of the bones? That's fine. It is the aqueduct of Sylvius. So it, yeah, exactly. You know it. Oh, wow. So, yeah, the aqueduct of Sylvius has something important about it, because when the patient has like hydrocephalus, we can differentiate the communicating from the non-communicating by looking at the aqueduct of Sylvius. It is, if it is patent, and actually we are looking mainly in the sagittal cuts. You can still look at the axial, but the sagittal is important, so you can see if there is obstruction or narrowing. So you can think about obstructive hydrocephalus, especially in kids. And if it's communicating and nothing is obstructive, and still you suspect an hydrocephalus, so in this case, maybe something else, and it is named communicating hydrocephalus, and it has a lot of reasons. And again here, so we have part of the brain start to appear. This is the temporal pool, it's a temporal loop, all of this, and this anterior part we named as a temporal pool. And this also part of this ventricles and C-SEF that we can see bilaterally. And this is also, I want to show you and make focus on this because it's important for us during tumors. When you assess a tumor, you have to look at every single space, like ventricles. Sometimes it's phased, and as you can see, it's tiny already. It is tiny, right? Sometimes if there is entrapment or like a mass effect, so you have C-SEF and there is a mass effect, so you start to have entrapment and it's increased in size. Sometimes you cannot differentiate, is this part of the tumor or is this like a ballooning and the entrapment of the ventricle? So you know, you have to know the anatomy very well. I'm trying to give you a brief, but this can help you during your project or during your work with breaths. And again, here you can note the difference in the white matter and here, but still, I can tell you something actually. It's hard to say about this because we already use the fat suppressed in these images. So the fat is suppressed, but it is dark in T2. It's dark in FLAIR, but it's not that dark because we use the fat suppression. So every fat is suppressed. But it's hyper intense on is the white matter hyper intense on T1. And again, this is the temporal lobe, this part of the occipital lobe, you can see bilaterally. And here, this structures also is very important. So again, this is fluvoid. So this part of the internal carotid artery bilaterally, okay, it's like a cavernous portion. And this part is the tip of the basilar artery. And here is the prepontine cistern. So all of this CSF, okay, and it's connected, like connected together. And you can see here also this ambient cistern is part of the basal cisterns here. And again, make sure, see the sulci, you can see the fluid is very nice here. Sometimes if you have a mass effect, all of this sulci is effaced. So you cannot see the nice picture of this fluid here. Sometimes maybe you don't have enhancing mass, just you have the mass effect and the effacement of the sulci, effacement of the ventricle. I mean, effacement like compression on something. So it's effaced like closed. When you see this, you suspect in a mass. Even if you don't have enhancement, you don't have anything to make a clue, just the mass effect and the effacement. That's why I keep emphasize on this, you have to look for. And here is the area of the medial temporal lobe, and start to have the hippocampus and the parahippocampal gyrus here. And again, this is the orbit you can see. If you don't know, is this T1, T2, always look at the orbit or look at the CSF fluid. It's bright, it's T2. And you can see part of the lens here. Okay, and we get more up, start to have here the sylvian fissure, and we have important vessels here. And the sylvian fissure of the other side, start to have the inferior frontal and orbital gyrus here. This is part also of the lateral ventricle. You have the occipital horn of lateral ventricle. So now you saw in the previous image the temporal horn, okay, and now this is the occipital horn of lateral ventricle. And this is the midbrain. You can see it as open like this, and this interpeduncular cistern. There's also a part of the basal cistern you can see here, and yeah, this area is the supracellular cistern, and actually it has part of the optic chiasm, if you can see here. I know this fine details for you, but just you can imagine. And here, this blood vessel is anterior cerebral artery, so it's like the previous cuts. Okay, so the previous cuts, this internal carotid artery start to terminate here, and the next cut give you the terminus of the carotid artery, and the middle cerebral artery start to originate here, and the middle cerebral artery on the other side, and the anterior cerebral artery start to originate here in this area as well. And this named mainly like a circle of wells. Also, you can see the basilar artery tip start to give you the posterior cerebral artery right and left. So this is the area of circle of wells and this important cut. Again here, the sylvian fissure and the temporal lobe, the occipital lobe here, right and left, and as we said, this start to appear the frontal lobe here. the other side. And here's is the inferior frontal lobe, the orbital gyrus, and the gyrus rectus is here. And again, the left temporal lobe start to end, and sylvian fissure is more wide because middle cerebral artery giving some sylvian branches here, right and left. So this patient probably, I can say like, he is older than 60 years because I can see the sulci and the ventricles are prominent than the younger age. So this happened with like aging. The brain starts to atrophy, the ventricles start to be prominent because it takes place of the brain tissue, right? And the sulci also and subarachnoid spaces start to be prominent, and this is expected with age. And again, we have here this cut with fluvoid vessels, and this is a place for ACA. The anterior cerebral artery, and we have here this part of the ventricles. Anyone knows what is this?
Third ventricle.
Say that again.
Third ventricle.
Third ventricle.
Yeah. Excellent. You are awesome, guys. You know it very well. I don't know if maybe that's not helpful for you, but I'm not sure if everyone has the same knowledge or not. That's why I wanted to emphasize on everything, to make sure like this is the basics, right? The anatomy, physics, that's the basics for MRI. Okay, so this is, and again, this is the end of occipital loop, and start to have after that, the next cut, the parietal loop. And here's a part of the occipital horn of lateral ventricle. Again, make sure you know it very well, how it looks like, because when I show you some lesions, you can imagine like the mass effect, and you can imagine how it looks like. And this, like here, you may say, oh, it phased here a little bit. Here's wider. That's fine, because here maybe some like white matter atrophy or something, and it takes the place of it. That's fine, or like a variant, normal variant. So we can expect something like this. Nothing wrong about it. And also, I want to tell you, did you see this? I know it's very, very tiny, but there is like maybe cyst, or see here. There is some like a bright signal here, and it's dark here in the area of the basal ganglia. Here and there, and it could be normal, it could be abnormal. Anyone can expect what is this?
You're lacking the imports?
It's a small,
Yes,
a small
and there is,
vessel disease.
okay, so it's not a small vessel, it's like a perivascular spaces. I know it can be infarct, right? Even us, sometimes we don't know, maybe lacunar infarct, because the basal ganglia has this area, and it can be cystic. I don't know. I have to
It
look
could
at it.
be Virchow-Robin's.
It can be like perivascular spaces. So every vessel, So every vessel has like a space of CSF surrounding it. Sometimes it's prominent, and you can see it always in this area. Like, and especially, you know what? Why I can say this perivascular? It's linear. Here, there, here, right? It's linear, and it's like it going in the same direction of blood vessels. So most of the time, this looks like a perivascular space, like we called as prominent perivascular space, unless you see something, okay, there is some flare changes around it, and it's very hard to decide from T1 and T2. For sure, I can say this like, infarct or something, but like if you see this in young age, you can say, okay, simply it is a prevascular space. It's a prominent prevascular space. Okay, let's go to next cut. Okay, and now at the cut of the lateral ventricle, and this very important cut as well, you can see the frontal horn very well. You can see the body. You can see the posterior horn of lateral ventricle. You can see some like hypointense signal. This is, do you know what is this?
The white plexus.
Yes, that produce CSF. So that's normal to see here. In some people or all people, you can see it's calcified. Sometimes it's like you can see something prominent. It's hypo. Is this a lesion? No, it's just calcified. Sometimes it's calcified choroid plexus, and that's happen. And the septum pellucidum is here. Looks good. I'm talking about like child or kids, patients. Sometimes you can see absent septum pellucidum if they have some congenital anomalies or something. And here again, this is the frontal lobe, and you can see part of the sylvian fissure here. And we call this like a frontal operculum and temporal operculum. That's the loop that's surrounding the sylvian fissure. And this is the end of the occipital lobe. The parietal lobe start to appear here, and you can see the parieto-temporal, that parieto-occipital fissure here that separates the parietal from occipital lobe. And again, here is part of the sinus, and the scalp here. The flow is very good. Okay, if you go more up, you can see part of the superior frontal gyrus. The middle frontal gyrus appear here, and this is the end of the lateral ventricle, and you can see here the white matter in this area. You can call it as corona radiata. If you go more up, called as central semioval here, like here. And here is the parietal lobe. You can see it bilaterally. And they start to have the central sulcus here. If we go more up, yeah, you can see the central sulcus here. So the superior frontal, part of the middle frontal here. And this is the precentral and central. This is the precentral gyrus, the central gyrus, and the postcentral gyrus. And this is important because you have here the motor areas, and in operation, they are always looking for these areas. Sometimes they cannot remove part of the lesion if that can affect the patient movement or like the motor areas, and they just do partial resection, and they continue with like gamma knife. They give radiation for the patient or chemo or something like this if they do partial resection. So all of this called the parietal lobe here, just the frontal lobe anteriorly. And I put everything together so also we can talk a little bit about the other sequences. So this name, the GRE, this is a flare. And I can tell you the importance of everyone. This is the diffusion and the ADC. So we talk about, do you know which molecule, which like element that's most famous in our body, the most prominent?
Hydrogen.
So hydrogen, and the hydrogen part of element, do you know what is it? Okay. What's the like 70s? Yes,
Water.
Exactly, water. So our body, most of our body component is water, right? And the diffusion can tell you something about that. So like, for example, in a stroke, when the patient, like the tissue died, right? And the sodium potassium pump stop to work, start to have some molecules and edematous changes, like swelling of the cells because no change of molecules, right? So the sodium, potassium bombs start to change, but once everything is shut down, the cells start to swollen, okay? And this means cells are swollen, the spaces between the cells start to efface and decrease. And the water is the thing that between the cells. And in this way, the movement of the water should be like difficult or facilitated or like easy when this happens. Should be difficult, right? So the movement of the water should be difficult. Why? Because swollen cells from here, swollen cells from here, and they efface the water in between. Like the water molecules cannot pass easily between the cells, and this leads to restricted diffusion. We called it, okay? So difficulty means restriction, okay? And this can help us to catch the signal in diffusion. So diffusion, weighted image, it depends on the molecules, the water molecules. As you said, the water is the most famous molecules in our body. And when this movement of the water is very hard and is restricted, start to give us a signal here on diffusion. So most of the signals that appear as a bright in diffusion, this means restricted or highly impacted or like tissue, you know. If this tumor has like highly impact tissue or like high grade or something like this, like for example, abscess can be restricted diffusion. And stroke, this is the first like line of treatment to just do diffusion, or like this is the protocol. If you will not do anything, just do diffusion and the flare for patient has a stroke. And once you see like a territorial infarct, like it's like territorial bright signal, you can catch it. It's like in hyperacute stage even. And it catches the signal before the flare. So this is the diffusion, can always help you to catch the highly impact tissue, or if there is like swollen tissue, there is some restriction of the water movement, okay? Once we have this like facilitated, we call it as facilitated, it doesn't give you a signal. So to say that, it should be the diffusion has a bright signal, and you have to look at the ADC. So the ADC is like the opposite of diffusion. It should be dark. So bright in diffusion, dark in ADC. Then you can call it as restricted diffusion. And also here, the flare is important because what? Because flare is like, if you can like imagine T2. T2 is part of, flare is part of T2, but it's like has a fluid attenuation. So it's T2 by the parameter of T2, but we just suppress the fluid in T2. So you can imagine the white matter should follow the same white matter of T2, and gray matter is the same, the bone, fat, everything. But the good thing about it, it doesn't catch the fluid. So if you have here a mass and the mass is bright, you cannot like, this is the ventricle, right? If you have a mass in the ventricle and it is a bright, you cannot differentiate it from T2, right? Because I mean, you cannot differentiate from CSF because both are bright. But if you do it in flare, you can see it very well, right? And the same here also, like can catch the edema. Sometimes like T2, you have like an area of cystic and edema, and like it's complex, but FLAIR can catch you. I'm talking from the like tumor perspective, but like for example, okay, this patient has like multiple hyperintensity. You cannot catch this in FLAIR, on T2, because here we suppress the water, so it appears as a bright, okay? And this called as microvascular changes. Different, like if you see this in patient maybe 60, 70 years old, and you can say, okay, this is a microvascular changes, like, it's like occlusion of in the vessels. And this also you can see is this in the subcortical and the periventricular white matter. And this common, very, very common in old age, like the brain atrophy is the same, like prominent ventricles. You can always see something like this like changes. But what if I see this signal in like a female, and like she's 30, 40 years old, and she has weakness, and you can see
Multiple
most
sclerosis?
yeah, excellent. Yes, exactly. You can, okay, this may be a demyelinating disease. Is some multiple sclerosis, especially if you find it's like periventricular, and like in arrangements that perpendicular to the corpus callosum or something like this. So actually this different in the clinical setting. Every patient has a different history and different age, and you cannot just say, okay, but most of the time we call this as a microvascular changes. But still, you need to know the difference between this changes, because in some patients you can see like a confluent and it's really extensive, and still you can say it is microvascular changes. But if the patient has a tumor, it's important to differentiate the microvascular changes from the vasogenic edema surrounding the tumor. And I will show you an example for this. So always keep attention to few things that can change your management, can change your diagnosis, or during your work with your project, you have to identify, oh, this is not part of the tumor. I'm not gonna segment this thing. And you have to know how it looks like, the vasogenic edema, the cytotoxic edema. So like, if I talk about cytotoxic, if this is like, okay, let me imagine this like a stroke. And you cannot, in cytotoxic, you cannot like differentiate the gray-white matter junction. Here you can still, in T1 and T2, you can, this is normal, but I'm just saying to imagine if there is something restricted and it take a territory, for example, for MCA, and you cannot differentiate the gray-white matter junction, then you start to think, oh, okay, there is edematous changes. Okay, no, looks like a cytotoxic edema. What is important about GRE is the calcification. We catch calcification, and you can see here is the bone. So calcification looks dark here, and also you can see hemorrhage. So calcification, hemorrhage can be like this dot. It's if you find this something here and there's a blooming artifact or something, you can say this hemorrhage or hemorrhagic mass. That's all about GRE. It's okay, and I can ask someone, I can, what do you think is this thing that bright? Or first, let me ask, which scan is this? You can tell me, is it T1, T2? What is this?
It's T1 with contrast.
Yes, exactly. Yeah, give me 1 second. Sorry, someone sent me something. Okay. Yeah. How do you know that? Who is this? Who's talking? Anyway, okay. So this is a post contrast because of what? Because I can see.
Yeah.
You can tell me. Okay.
You can see sinuses is bright and full of
Yes.
contrast.
Yes, exactly. And if you remember, we talk about these blood vessels in T2. If you remember, when we talk about flow void, it was dark, right? And in T1, maybe we couldn't appreciate it, but now the patient has a contrast. Oh, the patient got contrast after the T1. So we always inject contrast on T1. Okay, because if you remember, we talk about gadolinium and it was paramagnetic. It has a signal on T1. That's why we inject on T1. And this is how it looks like on T1 post contrast. So you can see, like, for example, this is the superior ophthalmic vein here, and I can see here, this is meningeal enhancement or dural enhancement, and that's normal. And here also there is some dural enhancement, and you can see as a reflection of the temporal lobe. And this is a transverse sinus here, right and left, as you said, and some like cortical veins here. And here also this like part of the cortical vessels, and here is part of the straight sinus. And again, this dural enhancement, since it's not thick, it's not nodular, because sometimes a patient has leptomeningeal disease, for example. And I start to talk about this if the patient has thickened, like around the meninges, and it's nodular, and it has multiple possibility. Could be like infection, like sarcoidosis, or TB, or can be tumor, right? Can be leptomeningeal metastasis. So this is important to identify this as well. But this looks like a smooth, and it's like similar and symmetric on bilateral and everything. So I'm not worried. There's nothing. This part of the confluence of the venous sinuses, and as we said, this part of the straight sinus start to have deep venous sinuses here. Sorry, the internal cerebral veins. And this again example of the dural enhancement again here looks okay. And the cortical vessels. I want to show you the cortical vessels because also this one of the things you have to pay attention in your segmentation, in your like images, in when everything is complex in post surgery. It's very hard to identify everything if you don't know the anatomy very well. And this is also part of the superior sagittal sinus. And again here, you can see the choroid plexus is enhancing, right, in the bilateral ventricles. Okay. So I just wanted to let you see this diagram to remember the blood vessels. So here is the anterior cerebral artery. This let's start by here. This is the circle of Wallace again, and this is the carotid terminus, and give the superior clinoid, supraclinoid, internal carotid, like the carotid terminus. That's enough. And they give us here. This is a tiny anterior vessel. Is the anterior cerebral arteries is intercommunicating. And on the other side that go to the Sylvian fissure is the middle cerebral artery, and they give us anterior and posterior branch here. If we look posterior, okay, let's start from down. So vertebral on the other side give us ICA and bica. Give us bica here. Sometimes it terminates as bica, and they are fused together to give the basilar artery, and the basilar artery on the interopeduncular cistern. You can see it here and give some branches, small branches here. And this anterior inferior, or we called as ICA, is originated from the basilar artery, and then here at the tip of the basilar artery, you can see the posterior cerebral right and left give like B1, B2, and distal branches, and just underneath it, the superior cerebellar artery, and there is like a nerve here in between. It's oculomotor nerve, so we know it as it's between the two blood vessels. Okay, and sometimes we have here the posterior communicating here. In some patients, if some patients they have a persistent posterior communicating as continuous as a posterior cerebral artery, instead of coming from the basilar and just like diminutive flow or something. So this is the circle of Wells. You have anterior intercommunicating, posterior communicating, the posterior cerebral, how it looks like. And this cut is like they cut the brain, the skull base, and just show you from inferior, like this, for example, this olfactory nerve, and this part of the ventricles and the choroid plexus here. Okay, and this is how it looks like in MRI. So this MRI with contrast, or maybe this part of MRA, and you can see here again which vessel here is the middle cerebral, and again here's the middle cerebral, and this is the carotid terminus here, the basilar and posterior cerebral, and this the distal branches of posterior cerebral as B2, B3. Okay, and again here another image so you can memorize it. Maybe here the anterior cerebral is hypoplastic, so we cannot see it. And this angio, you can see the blood vessels here very well, and the brain tissue is suppressed. Okay. Now, let's talk about artifacts and this part of our life every day. You have images to read, but sometimes you cannot read, and it's non-diagnostic because the artifacts. And I think anyone who works with the brats suffering from artifacts in some images. Is this correct?
Yes, exactly.
Yeah. Yeah, even we can write a paper about just artifacts in brats, because you collect images from different institutions, and maybe you have artifact ingredient, maybe you have artifact in SWI, but you don't have in DWI, you don't have in T1 and T2 and the post contrast. So you just share your images, but if you look carefully, you still have some like deficiency in your images, and this happened, and nothing wrong about it, because yeah, anyone can share his images and didn't like look for every single sequence. So for example, this named like susceptibility artifact, and this is like SWI, and you can see here there is susceptibility artifact here and there, and because the patient has meningioma and they removed it, and there is like some metallic here, or there is some clips or something, they put some prosthesis here, and you can see this artifact. It obscures your imaging in this part, but yeah, you have to identify it. And even we are mentioned this in our report, and that's it. What should we do? We cannot assess this part because there is susceptibility artifact. Okay, there's another artifact. So this happened because they took like a small field of view, and this named aliasing artifact. When they repeat the images with large field of view, it looks better, and yeah, they can call as wraparound, as you can see here, and it can be corrected. Like some artifacts can be corrected, some artifacts we cannot. And you have always pushed the technician to like, sorry, I didn't know that we expand our time. I don't know what's the expected time for you guys. It should be 1 hour, right?
Yeah, 1 hour, but we can spend a few more minutes.
Okay, I will do this very quickly. I just wanted to show you much images as I can. And this name, the pulsation artifact, and this happened in the phase including, you can see here the internal cerebral artery right and left, and there is artifact here. And this T1 images. So it also obscures the hippocampus, and I think this patient maybe has seizure or something. So they cannot assess the area of concern because this artifact. You can see here, no, this is not a lesion, it's just artifact and coming from the pulsation of the blood vessels, and this common in this way. Another artifact that we start to see this here in US, maybe I didn't see before, maybe because they start to innovate and have a lot of hair extension, basing, facial basing, makeup, some eyeliner or something. A lot of this has a nickel or has like a titanium. I don't know which component exactly, but it has a lot of artifacts for us. And some patients refuse to remove the hair extension, or they refuse to remove the thing that they have. And unfortunately, the images are non-diagnostic. We cannot say anything about this. So also I want you to be familiar with this. And again, this artifact, because maybe the patient has eyeliner or something like this. Oh, no, this is the mask. Oh, okay. So this is the face mask. The patient has the metal of the face mask, and that's happened at the time of COVID, and I think they start to flip the metal to be under the chin, so the images will be corrected. Yeah, this is the patient has tattoo, eyeliner, it's like permanent or something like this, and also it obscure and cause some problems here with the eye globes. Okay, quickly, I will review some images for pre-treatment and the post-treatment. So, for example, this patient has some enhancement here, and we catch a lesion here. You can see also there is some gyral thickening, and they took out this mass, whatever is this, and I wanted to show you some post-surgical changes, how it looks like, what's the expectation for this. So you can see the restriction cavity, it has a fluid level, and again here's a post-contrast. You can see there is like a fluid level here, there is some enhancement at the restriction cavity here, and this area of craniotomy they took the lesion from, and there is some meningeal enhancements. Is like way more than what we saw before, right? When we say, okay, we can expect some meningeal enhancement, but not like this, right? I don't know, maybe the patient has a recurrence at this area. I can say maybe this like a reactive meningeal enhancement as a post-surgical changes. And this fluid level, it should be expected as a blood. We can expect some blood in the surgical cavity, and also in FLAIR you can see the blood very well. It's hyper intense, as you can see here. There's some subdural hemorrhage here, and all of this is expected. And even if you see some thickening, if you look at the immediate images after the surgery, you can say like expected post-surgical changes. But once the patient has a follow-up after 3 months or like 6 months, and you still see the same findings, no, this is probably a tumor. If you see enhancement, maybe leptomeningeal metastasis, and even here, this enhancement around the surgical cavity, you don't know, maybe start to have recurrence, or maybe this residual, they didn't take it out. Okay, and again, you can see some subgaleal hematoma and the scalp hematoma, and this is expected as post-surgical changes as well. This patient, okay, we look here, and if we found something, is this a flare, right? Is this like edema, right? This is not a mass. Maybe it's a mass. No, it doesn't show enhancement. What about the T2? Here is the point. T2 is very hard here because you cannot differentiate the ventricles from the edema, right? But you can hear in flare very well, and you can assess all the ventricular changes in flare, right? So you can see here the posterior horn is really, really compressed. And again here, this effect on the frontal horn is compressed and effaced. And there is some entrapment on the right side. So all of this a mass effect. And you can simply know the vasogenic edema. It's like a finger-like. It's you can see it's like subcortical. It doesn't touch the cortex. It's just spreading subcortex, and this in opposite to the cytotoxic. So cytotoxic, you cannot differentiate the gray-white matter junction, and you can differentiate this here. So all of this, like a vasogenic edema from the tumor, maybe it's low grade, it doesn't have enhancement, and just it's T2 flare hyperintensity. This can be happen with low grade glioma. And also I want to show you, you can see here some T2 flare hyperintense foci. Do you know what is this? Is this part of the tumor? No, right? This should be a microvascular changes. This is not part of the tumor. And also I want to show you, this is the same patient after surgery. They took out the tumor, and again, there's T1 hyperintensity here. This could be a blood, right? And this is a surgical cavity, and if you see this in T1 hyper and post is hyper, you cannot say this is enhancement unless you have subtraction images. So it can subtract the hemorrhage and can just show you the enhancement or the gadolinium. And still you have some mass effect, and you have a vasogenic edema here, and here the ventricle is effaced, like totally effaced here. All right, that's all that I have.
Thank you so much, Dr. Tahon. That was a very comprehensive talk, and we learned so much, and I think we're all ready to be radiologists now.
Yeah.
Thank you so much. Does anyone in the audience have any questions for Dr. Tahon? Yes, Magnus?
I hope you get benefit from this talk. I tried to be simple. I know it's a lot of things, but I don't know what's the main of giving you the basics, but this my understanding. The basic is anatomy, physics, and talking about the things that you will facing during your segmentation, during your work with your project. And I hope all the best to you during your work with your project. And let me know anytime.
Yes, thank you so much. Thank you so much. Nikolai, yes.
You're welcome.
First of all, I would like to thank you for this comprehensive lecture. It was really comprehensive, and we can continue to talk for like hours about MRI basics in neuro. So I have two questions. My first question is related to the gradient echo sequence, and is there a difference between melanin, how melanin and blood look on gradient echo like? So my question can be paraphrasing to: is there a way to differentiate between metastatic melanoma from some metastasis that bled into itself?
I know. That's so intelligent question. I want to tell you, we are in the tumor pool, it's very hard, to catch the difference. Sometimes we say this is melanoma, okay, but it should be enhancing, so it is enhancing, okay, but it's hyper in T1. And what about the hemorrhagic lesion? It's a lot. Sometimes we don't know. Sometimes we just biopsy, and it's not that easy because also the blood sometimes it's enhancing, right? So I think biopsy is gold standard for this. Yeah, and as you know, so the melanin can give you a high signal in T1 and can be like this.
Okay. Thank you very much.
Yeah.
Do we have any other questions? Okay,